These are really high challenge cases that we kind of give you here. And as Nigel said, like the beginning of me starting here, I'm really here to challenge you and push you and to pick up those moments where you might say something that maybe it's jargon or word I don't understand. I will be very quick to question you on that. And in real life, your patients probably won't actually. I know even the work that I do, when I go and see my doctor, if they say something I don't understand, I tend to well, because I'm concentrating on what they're trying to tell me, I tend to either ignore it in the moment or forget it. And then I go away and think, what was that word they just used? And then I'm trying to Google it and come up with all sorts. So in reality, your patients will probably just ignore it and feel a bit confused and perhaps a little bit alienated and go away. But, we're here to really pick you up on those things. And, hopefully it will be helpful for you going forward, when you're with your real life patients, like terms you take for granted, like pathways or whatever else, contraindications, that you don't maybe perhaps realize that sometimes these might not make sense to a patient, or that this isn't common language for a patient to hear, particularly younger people. And really, that's one of the main things in terms of when I'm talking about feedback for today's session. Language is something to think about. Be careful, no jargon, keep it simple. As I say, words like contraindication comes up a lot, and lots of people do know what that is, but lots of people don't, and particularly young people. So be really mindful of the language you use when you're talking to patients. It never needs to be like some kind of, it can always be simple and neutral. You never have to use jargon with a patient. If you're using jargon, it's suggesting to me that you're doing that for the benefit of the examiner rather than the patient. And it should always be about the patient. The examiners want to see how you talk to patients, not seniors or examiners. It's a face-to-face, it's a patient facing job. This is the job of a GP. So think about language. And the other thing that struck me from today is just really being confident to make a commitment to things, a commitment to saying no to a patient if you need to, the commitment in doing that and doing it clearly, firmly, fairly, kindly, but doing it nonetheless, making sure you're verbalizing the no and then spending time on thinking about what you can offer. And then committing to the risk as well. When we're talking about the HRT case, again, if you've got the knowledge, if you know that the risk is low, then verbalize it, feel confident that you can do that. So yeah, that was the main thing, your commitment, your confidence in what you say. And remember that there is never another appointment. The examiner is only going to see this appointment. There's
That's
never
right.
another phone call. There's never another video
Unless you
consultation.
have to resit the SCA, but hopefully that's not gonna happen again. It's like I'll see you in the resits. So obviously we don't want that to happen,
We
of
don't
course,
want
to
that.
any
We
of you.
don't want that. No.
No, no,
So,
no, no.
but yeah, so just be mindful to deal with these things in this consultation. But I wish you all the very best of luck. Lovely, you've lovely people, lovely personalities. They all come through really lovely, and that's something that you can't teach. That natural kindness, actually, that I see in all of you. So just make sure you demonstrate that with your AEE, that lovely kindness. But well done and good luck.
Round of applause for Lou. Thanks so much, Lou. Okay, so we are going to now start talking about score prediction.